Okay, good afternoon, our mentor, Dr. Suthorn, and also all participants. So today I would like to share you about the surgical planning of the cerebral triad injury of the elbow. So to build a successful operation on this kind of injury, so what we need to know. First, you need to know what structure give the stability to the elbow. Second, in this injury, you have to identify all of the injury structure that may cause the instability of the elbow. And you have to address and treat all of each injury structure to make the injury successful. So you have to make sure that you make the joint congruent and also stable and have a good motion. So for the stability of the elbow can be divided into 4 columns. So the anterior, medial, lateral, and the posterior. For the cerebral triad injury, the injury involved in 3 columns, including of the anterior column, which is the choronoid process, brachialis muscle, and the anterior capsule. The lateral column is the radial head, the lateral collateral ligament complex, and also the capitulum. And for the medial column is the choronoid process, the MCL, and the medial condyle, and also epicondyle. So when I was like a resident and I read the textbooks, the cerebral triad injury, including of the radial head fracture, the choronoid fracture, and the elbow dislocation, which is usually implied to that the LUCL injury. But it's not that all. It still have some occult injury that sometimes we maybe overlook it. It's including of the AMCL and also the anterior capsule. Or sometimes they also have the other concomitant fracture too. So for the planning of the radial head and neck, you have like many choices from the conservative treatment, fixation, and replacement. It depends on the type of the injury of the radial head and neck. And for the surgical approach, you have the workhorse approach from the lateral side, from the anterior to the posterior, is Kaplan, EDC split, and Coker. And for the LUCL, you can also treat it conservatively, repair it or reconstruction it if it's in the late case, with the same surgical approach from the radial head. And for the choronoid fracture, you can conservative or fixation, it depends. And this injury have many ways to approach it. From the medial side, we also have 3 surgical approaches from the anterior Hotchkiss, FCU split, and the Taylor and sham. And you can also assess this fracture from the lateral side if you have to take off the radial head, so you can see the choronoid from the lateral side. And also you can direct assess this fracture from the anterior. So let me share my case. And this is not the rule, because for the cerebral triad injury, you can also approach it in many ways. And what I did is maybe it's not the best. It's just one from the many ways to treatment this kind of injury. So first case is a 63 years old female cross injury. So first we need to identify the injury, right? So from the CT scan, you may see this. This is a choronoid fracture, quite small, should be type 1. And the radial head fracture, this like a 2-piece. But if you look at this, you look at this neck area, it's like an impaction. This is when you reduce it will have the void. So sometimes I call this the comminute or the impact of the radial neck. So some maybe call this is type 2 fracture, but I usually classify this as a type 3 fractures. You can also see this. This is the minimal displaced lateral epicondyle fracture. And also for the elbow dislocation, we usually have the LUCL injury. So after you identify all of the injury structure, so you have to plan. First, I plan. For the radial head, this maybe can fix, but also these patients are elderly and comminute, so I back up the radial head prosthesis. For the non-displaced, minimal displaced lateral epicondyle fracture, sure, fixation. And the LUCL injury should be repaired. And for the coronoid fracture, you may repair it or not. It maybe can conservative or you can fixation. So this injury in this patient, so we have to go for the lateral side, and maybe sometime we may go to the medial side. So this case, I took out the head, and the neck is too comminute, so I do the replacement. And I also fix the lateral epicondyle with the screw. And also there are the ankle suture here to repair the LUCL. And in this case, I leave the organon conservatively. I put the patient on the elbow brace and did the early motion. And you also can find that there are the wire here around the proximal radius, because it's like some crack when I did the proximal radius replacement. So this is the result after 3 months. It's quite good. So the next one is a 62 years old female, cross injury also. So first step, we identify the injury, right? So this coronoid fracture. This case is quite big. It's maybe type 2. And also radial head fracture. It's like a 3-piece, and no radial neck fracture, and the LUCL injury as well. So this is a classic cerebral triad injury. So this case, we operate her on at the 4 weeks after injury. It's because the COVID problem. It's not the patient problem. It's a doctor problem. So we have to delay the surgery. Okay. So in this case, it's like a multi-fragment. Should be like a type 2 or type 3, but no fracture neck. But in this case, I think if you do it early, we can fixation. But I'm not sure now. It's like a month. So it's maybe malunite, and I did not sure I will. When I took it off, from the malunite press, it's maybe cracked or something. So I also back up the prosthesis as well. For the LUCL, sure, for repair if we go to operation. And the coronoid also need to be fixed. So in this case, we plan to be lateral and also medial. For the combined lateral and medial approach, you have 2 ways. So you can have the splitting incision, one incision at the lateral and another one on the medial. Or you can have one last incision at the posterior, and you create the flap to go to medial and lateral. So in this case, because of the radial head, the piece at the head is like a soft, so we cannot fix it, so we have to take it out. So when I did this, I tried to leash the orecranon from the lateral side, but it's also struck because it's like 4 weeks. So I have to create another incision on the medial as well. And after I did that, I found that the coronoid fracture is almost healed. So I just augment it with the pull-out suture and also repair the LUCL. So this is 2 months post-operatively. The joint is quite good. Another case is like a multiple trauma patient, 41 years old female with the elbow injury. You can see that the coronoid fracture here and also subluxation of the elbow. So when you go to CT scan, you can see the coronoid fracture type 1. Also, the radial head fracture is like a non-displaced marginal fracture. It's maybe type 1 radial head fracture too. And this also have the posterior trochlea fracture. It's like a impaction when it dislocated. and also it's non-displaced, and also LUCL. So this is the cerebral triad variant. So planning for the radial head type 1, yes, sure, we can conservative it. The coronoid fracture, we can also conservative it, but in this case, I plan to fixation from the anterior approach, and the LUCL repair from the lateral approach, and the trachea, I will conservative it as well. So in this case, my plan is to go anterior and to go lateral approach. So first, I start with the anterior. I go the anterior approach to put the plate over the coronoid to buttress it, and also I also suture the anterior capsule to the remaining hole of the plate as well, and then fix the LUCL. This patient is still on the hospital, so this is 2 days ago on 19th day post-op. Because I put all of my cerebral triad patient on the elbow base, so she can move like this. Okay. For those who is not familiar about the anterior approach, I will quickly review for it. You can find it in this journal, in this article. This is a free article, so you can access it. So first, in this article, they did the lazy S curve incision like this, and when you go inside, you will see the bicep aponeurosis. This is like a thin layer of tissue. You go past it through it, and you have to retract the bicep muscle and the brachial artery to the lateral side, and you retract the medial nerve to the medial side. And after that, you will see this is the brachialis muscle, like when you did the anterior approach of the humeral shaft. You split the brachialis, and you will go to the coronoid. This is what I did. So you retract the bicep and the brachial artery lateral, the medial nerve medial, and you see the brachialis muscle here. Split it, and you will see the bone. And you can press the plate direct anterior to the coronoid. Okay. Another case, the last one, is a 58-year-old female cross injury. This is elbow dislocation. This is post reduction. You can see still have some subluxation, like a very small piece at the head, and maybe some part of the coronoid here. So I go to CT scan. You can see the coronoid very small, type 1 coronoid fracture. Also the very small radial head piece here, and the LUCL. So this is cerebral triad injury. So my plan for the small marginal fracture of the radial head type 1, sure, conservative treatment. Coronoid, maybe fixation, or maybe you can did it conservatively, and the LUCL repair. This is my plan, but the patient asked me, "Doctor, no surgery, please." So I have two choices. First, to give a chance for the bone setter to treat her, or the second one, I have to consider, can this case treat with conservative treatment? Is it possible? Yeah, the radial head can be conservative treatment. The coronoid also can be conservative treatment. So I did the conservative treatment as the patient asked, like this, because the cerebral triad injury in this case is look quite benign, right? So I put her on the cast, on the posterior slab for 3 weeks. After that, I put her on the elbow brace. This is at the 3 weeks. You can see the joint also constrained. And this is 6 weeks. She can did the early motion with the stable elbow. So to achieve the good outcome in the cerebral triad injury, you have to identify and treat all of the injury structure that may be possible to occur in your patient. And the key to success is to make it congruity, stability, and mobility. Thank you.